Moving on to arterial supply of the stomach. And we know stomach is basically supplied by the celiac trunk system. Stomach is developing from the foregut, and most of the organs which arise from foregut are deriving their blood supply from the celiac trunk system. And you have to be very thorough with the arterial supply of the stomach. Okay, not only for stomach surgery, even in esophageal surgery, when you do gastric conduit, the arterial supply is very important. Okay, most of the second echelon lymph nodes with respect to carcinoma stomach are in and around the blood supply of the stomach. You have to remember that. So what are the important arteries? Left gastric artery, we know left gastric artery is a branch of celiac trunk. We have right gastric artery, and right gastric artery is a branch of common hepatic artery. Okay. We also have gastroepiploic artery, which is a branch of gastroduodenal artery, and gastroduodenal artery is a branch of common hepatic artery. We know that. Left gastric artery and short gastric arteries both are from splenic artery. Okay. So those are short gastric arteries which are supplying the topmost part of the greater curvature. Okay, short gastric arteries. Remember that. And the left gastroepiploic artery. These two are branches of splenic artery. Okay. There is rich anastomosis between all these blood vessels. You can appreciate here. There is a very rich anastomosis. There is good submucosal plexus of these blood vessels. That's why it is an organ which heals very well. Okay, whenever you do surgery over the stomach and if you have done anastomosis, it will heal very well because there is very rich blood supply. If you have done gastrojejunostomy, it rarely leaks. Okay, because there is a very good blood supply. That's why the ischemia is rare. It can happen, but ischemia is very, very rare in the stomach. So remember the arterial blood supply of the stomach. With respect to venous drainage, we know stomach drains into the portal system. The left and right gastric vein will directly drain into the portal vein. The left gastric vein is also called as coronary vein. Don't forget this. Okay, sometimes rather than calling it as left gastric vein, people will say coronary vein. Remember that. Okay. The right gastroepiploic vein will join superior mesenteric vein. The left gastroepiploic and short gastric veins will join the splenic vein. Whenever you have portal hypertension, the patient will have gastric and esophageal varices. And it is with respect to venous drainage of the stomach. I have discussed in detail about this in the module on portal hypertension. But for now, remember that whenever there is portal hypertension, the patient will have gastric and esophageal varices. That's the venous drainage of the stomach. Coming to lymphatic drainage of the stomach, this is very important for cancer. If they ask you a long question on the stomach, probably it will be from the lymphatic drainage of the stomach. And it is a favorite topic. I will discuss about the lymph node stations also. It is a favorite topic for INI and NEET SS examination. Remember that. So traditionally, the cardia and proximal part of the lesser curvature will drain into the left gastric nodes. Okay. So if you divide the stomach into two halves, okay, and then this is the right half, and right half you divide proximal 2/3 and distal 1/3. So the proximal 2/3 will go into the left gastric node, will drain into the left gastric nodes. The distal 1/3 will go into the suprapyloric nodes. Okay, it will go into the suprapyloric nodes or right gastric nodes. Okay. Coming to the left half of the stomach, you divide it distal 2/3 and proximal 1/3. So the proximal 1/3 will drain into the pancreaticosplenic nodes, and the distal part will drain into the subpyloric nodes. Subpyloric nodes. Remember that. Okay. And all these lymph nodes will finally drain into the celiac nodes, and then the lymph will enter cisterna chyli and it reaches thoracic duct. And the thoracic duct, we know, it traverses through the thorax and it will drain finally, and you can have a virtuous node there. Okay, left supraclavicle node in patients with carcinoma esophagus. In carcinoma stomach, though the patient has stomach cancer, they can have an enlargement of left supraclavicle node called as virtuous node because the lymph travels along the thoracic duct. Okay, so that is the lymphatic drainage. That is the older way of describing the lymphatic drainage. Okay, it is still relevant, but that's the vague way of describing the lymphatic drainage. But nowadays we have lymph node stations, and this is very important for your clinical practice. If you are doing surgery on stomach cancer, surgery for stomach cancer, then they are going to ask. This is very important with respect to carcinoma stomach. Whenever you are doing surgery for carcinoma stomach, we have something called as D1 gastrectomy, D2 gastrectomy, D3 gastrectomy. Some people say D4 gastrectomy also. Okay, we'll discuss about all these things in the module on carcinoma stomach, but you need to know about the lymph node stations with respect to stomach. What are these lymph node stations? It has been labeled from 1 to 16. Okay, with respect to stomach. Okay, for stomach we have 1 to 16, and you have to remember these things. You have to remember lymph node stations, because they will ask you what is lymph node station 9, what is lymph node station 12, what is lymph node station 16. So you should be able to tell. Maybe difficult to remember, make all the attempts to remember this lymph node station. So lymph node station 1 is right paracardial lymph nodes. Okay, that is the pericardium. Here is the pericardial region. So station 1 is right pericardial lymph node, station 2 is left pericardial lymph node. Then you have station 3. Okay, station 3 is along the lesser curvature, and that is along the left gastric artery. In station 3, you have station 3A and 3B. What is 3A? Lesser curvature lymph node along the left gastric artery, and lesser curvature lymph node along the right gastric artery. Okay, that is station 3A and 3B. Station 3 is along the lesser curvature. If the lymph node is along the left gastric artery, then you call it as station 3A. If it is along the right gastric artery, it is station 3B. Lymph nodes along the greater curvature are labeled as station 4. So the station 4A is lymph nodes along the left greater curvature along the short gastric artery. 4B is lymph nodes along the greater curvature with respect to left gastroepiploic artery, and 4D is greater curvature along the right gastroepiploic artery. Okay, so this left, right and right may confuse you. So easier way to remember is 4A is lymph nodes along the greater curvature with respect to short gastric artery. 4SB is greater curvature lymph node along the left gastroepiploic artery, and 4D is lymph nodes along the greater curvature with respect to right gastroepiploic artery. Then we have station 5, which is suprapyloric lymph node here, that is the station 5, and then you have station 6, that is infrapyloric lymph. Okay, and all these are first echelon lymph nodes. Okay, these are also called as perigastric lymph nodes. Okay, and when somebody says D1 gastrectomy, then it means they are removing all these lymph nodes, station 1 to station 6. Okay, so you have to remember all these lymph node stations. Okay, what are the other stations? The second echelon stations, and this second echelon lymph nodes are along the major blood vessels of stomach. Okay, and what are these? They are station 7 to 14. And what are these? They are station 7 to 12. Remember. So what is station 7? Lymph node along the root of left gastric artery, this one. At the origin of left gastric artery from the celiac trunk, that is station 7. Station 8A, lymph node along the common hepatic artery. Okay, 8A. A stands for common hepatic artery. Station 9 is lymph node at celiac trunk, that one. Station 9. Station 10 is lymph node along the splenic hilum. Okay. Previously, people used to routinely remove station 10 lymph node during D2 gastrectomy, but nowadays people are not removing station 10 because previously surgeons used to remove station 10 lymph node routinely during D2 gastrectomy. But it was subsequently realized that it is not important. So nowadays people don't remove station 10 lymph node whenever you are doing D2 gastrectomy routinely. That is the significance of station 10. Okay. Then we have station 11, lymph node along the splenic artery, and we know splenic artery has a long course. That's why the station 11 has been subdivided as 11P and 11D. P stands for proximal, D stands for distal. Okay. So that is the lymph node along the splenic artery in the proximal part, and 11D is the lymph node along the splenic artery in the distal part. Then we have station 12A, that is lymph node along the proper hepatic artery, 12A. Okay, we also have 12A, 12P and 12B. I'll tell about all those things in subsequent part. We also have station 14V, that is lymph node along the superior mesenteric way. And station 16 is para-aortic lymph nodes. Para-aortic lymph node. And they are considered as metastatic. Okay. In Japanese, people are also removing para-aortic lymph node, and they call it as D4 lymphadenectomy when they do stomach cancer surgery, or D4 gastrectomy. But you know, station 16 is para-aortic lymph node, and it is further subdivided as 16A1, 16A2, 16B1, 16B2. I don't think they are going to go in so much of detail, but it is better to know. The lymph nodes along the aortic hiatus are 16A1. Okay. Lymph nodes from the origin of celiac artery from the aorta till the left renal vein is 16A2. Okay. The lymph nodes from origin of left renal vein to the origin of inferior mesenteric artery, it is 16B1. And lymph nodes from the origin of inferior mesenteric artery till aortic bifurcation, it is 16B2. Okay, that's the subdivision of station 16.